name is Melvin Churchill. I'm a rheumatologist here in Lincoln, Nebraska, and I'm here today to talk about rheumatoid arthritis. Rheumatoid arthritis is an inflammatory form of arthritis that affects young people. Unlike the degenerative forms of arthritis, which tend to come later in life, this will impact people in the prime of their life, childbearing years, when you're raising a family, and this really is a problem. This causes stiffness, swelling, fatigue. It may cause you to be febrile and actually have fever. You may have so much inflammation you think you're coming down with any number of things, including the flu. But in reality, this is a disease of your immune system, and if we treat it early and treat it effectively, we can make a real difference. It's really based largely on the history and physical examination of the patient. We listen to the story, we hear them tell us how stiff they are, how their joints won't move, how they're swollen, how they have problems sleeping at night because of the pain. And it can come on intermittently, mildly at first, or sometimes it comes on abruptly and you wake up one day and almost everything's swollen and puffy and it's very, very difficult to move. So the physical exam is very important in addition to the history. We look at the joints, and it's the distribution and the quality of the swelling that allows us to make the diagnosis. It's more often seen in the small joints, particularly the hands, the fingers and the wrists, and the feet, particularly in the forefoot, but it can be in almost every joint in the body. It tends not to affect the spine for the most part, but it's largely what we call peripheral or extremity-related joints. Once we see the physical findings and the history, the diagnosis is perfectly secure. In actuality, blood tests, for example, the rheumatoid factor and CCP and ANA, these autoimmune markers that we use to identify autoimmune arthritis, are helpful and confirmative, but the real diagnosis is based on just how the patient looks when you take a look at them physically. Blood tests are very helpful. They tell us how severe the disease is. They may show us how much inflammation there is, so we can monitor how well they're doing and monitor for any medication-related side effects as we follow the course of management with the new medications we're using today. Unfortunately, we don't specifically have an underlying cause identified. For many years, it's been felt to be, at least in some respects, genetic. Other times, it's felt to be related to some outside environmental product, possibly a virus. It's never been really clearly identified. But certain people are more susceptible than others, but there's no single genetic code that tells us exactly which patients are going to have rheumatoid arthritis. It's clear that certain family groups may have more arthritis than others, so there's more to be learned in this area. It's more often seen in young females than males. It can be seen in relatively young people. There are juvenile forms of what's known as rheumatoid arthritis, but we now call that juvenile idiopathic arthritis because it has a different course of development, and its evolution and treatment can vary considerably compared to adult forms of rheumatoid arthritis. It's important for the patient to come to grips with the diagnosis. So first and foremost, you need to contact your physician, who should probably have you see a rheumatologist to confirm the diagnosis and outline the treatment plan. We institute a group program, if you will. I have the patient involved with their primary physician to be sure they have all their health maintenance items covered on a consistent basis, because not every patient with rheumatoid arthritis has just rheumatoid arthritis. They may have high blood pressure and other comorbidities which actually impact their life. Rheumatoid arthritis can influence longevity and even shorten longevity by as much as 10 years. And unfortunately, the problem is that the inflammation of rheumatoid arthritis promotes other diseases, cardiovascular, cerebrovascular disease, namely heart attacks, strokes, kidney problems, heart failure, diabetes. All these conditions are more common in individuals with inflammatory arthritis, such as rheumatoid arthritis. If we control the disease process, we help control those other diseases as well. So it's a team approach between the rheumatologist and the primary care physician. In addition, we have good quality nurse educators. We involve physical therapists, so we have the right exercises and all the physical modalities in place for these individuals to provide comfort for their joints and maintain good strength. And finally, we might actually have nutritionists involved. It's critical that individuals with this disease have really good nutrition. If you don't fuel the engine properly, you can't help yourself feel better as well. So it's critical that we have all these parts and pieces of the puzzle and the treatment program all pulled together at the same time. When the patient has a proactive and takes advantage of this team approach, they do the best. You know, when you don't feel good, you don't eat. People actually become malnourished with this disease. They may actually lose weight and feel so badly they aren't even taking the time to feed themselves properly. What really helps rheumatoid arthritis is well-balanced meals. Probably best to do the things that are best for other conditions. For example, not too much fat, not too much carbohydrates. You should have plenty of protein. And it all needs to be balanced and put together in a program that maintains good weight balance. You don't want to be gaining weight and putting extra stress on your joints. So it's a matter of, you know, weight control, but yet adequate nutrition. The newer treatments may include immunosuppressive drugs because we're dealing with an immune system that's out of control. I tell my patients it's like a motor with no governor. It's racing. And you need to put a governor on this condition and make sure you have it under control. It's very, very critical that we do that. So we try to induce what we call as a remission as soon as possible. It's clear in all the clinical studies that have been produced that early treatment produces better outcome. So early diagnosis is critical and early treatment is critical. And we don't hesitate to institute anti-inflammatory agents in combination with immunosuppressive drugs like methotrexate. And then finally, within a short period of time, if that's not enough, we go into a combination with the traditional disease-modifying product, such as methotrexate, and add a biological product. And there's a host of those on the market now that have been developed, and they're remarkable products. They're monoclonal protein-like agents that influence and attach to these proteins that are causing inflammation in this person's tissues, in their bloodstream, and their joints. And by neutralizing these bad proteins, if I will call them as such, they're pro-inflammatory cytokines is the real word for them, but these proteins are stirring up the pot. They're making everything inflamed, and we can neutralize those now. So the combination of anti-inflammatories, traditional disease-modifying agents like methotrexate, and finally these biological disease-modifying agents are really the Cadillac program that we have available today. Well, arthritis will cause your joints to be stiff and tired and uncomfortable, and so it's important to exercise gently, warm them up slowly, simple range of motion activities, things that can be done on a simple setting with a floor mat, or possibly water exercise, for example, is probably the most comforting. You can have no impact, you have excellent range of motion in the joints, and moving slowly but surely to loosen yourself up in the morning is very, very important. We don't want to lose muscle tone, so we consider using extremely light weights, maybe rubber tubing, what we call surgical tubing exercises, sometimes small medicine balls, very light weights. But range of motion needs to be maintained, and you try to maintain some muscle tone. So you do probably less weight, less impact. We'd like elliptical machines and bicycles as opposed to running. If you happen to be a runner and develop rheumatoid arthritis, you may need to back off for a while until the treatment comes into play and allows you to do some of those things again. Hopefully you will be able to. But if not, you need to modify what you're doing, but still keep moving. That's really important. You have to move, otherwise you do get stiffer, you get weaker, and actually, once you start moving, you feel better. There's no question that having the ability to make yourself do that and having the motivation to do that has to come from within. But fortunately, we have partners that can help you. Physical therapists can provide programs. Many water facilities have arthritis training programs. I know there are a number of facilities in our community that offer these things to people with arthritis. So it's important to access those things that can make you feel better. It takes mental effort, but it's worth every second of the time you put into it. I can sit here now and tell my patients, we can help you, and I'm not fibbing. I really can make a difference. That's been a real joy, and it's made the field of rheumatology very, very active in the public eye. We have sports figures that are talking about it. There are lots of people in this world that realize that they have arthritis, and now they have choices that can make a difference in their lives. So it's been a real incredible change in the field of rheumatology and the treatment of rheumatoid arthritis.